we are going to move on to talk a little bit about some QI supports and then as well just what's next. So I'm going to pass it over to Cole again, who is going to talk a little bit about the QI supports, and then Andrew will take over from there after that. So Cole, if you're ready, I'll pass it over to you.
Yeah, I'm going to just share my screen again here, and I guess we didn't really figure out where to fit this in, so I'm just going to do it now. You see my screen okay there?
Yeah.
So just this is like a little sidebar. I think some people who are using the Interior Health OUD form have had questions about how we get the retention measure, so the outcome measure for retention, and maybe wondering how their numbers aren't aligning with what they think is going on. So we talked about this as a core team, and we think one thing that may be contributing to discrepancies is that people may be missing hitting restart or new start when a person does actually need to go back to the starting dose of a medication because of they've been off of it for a while, and you're needing to do a restart. So for those people, we don't want to count them as being retained greater than 3 months, right? But I think what may be happening with some of the teams is because the default prescription type here is dose unchanged, it's possible for the prescriber to enter a restart dose here without changing that to restart. So that means you may be counting some people as retained when in fact they shouldn't be in that numerator because they have restarted. So if you're seeing like 100% retention and you're saying that's not right, I don't trust that data, this is what may be going on, is the fact that even though you are restarting people and they've been on it uninterrupted for less than 3 months, that the system isn't picking that up because the prescription type has not been changed to restart. Now, I talked with Andrew about ways that maybe the EMR team should improve the design of this, so it would kind of warn you when a restart dose is entered, or just make it easier to do a restart and get the data captured. But is that clear to people? Does anybody have follow-up questions around that?
Jennifer has just a question in the chat about if the slide can be emailed out so it can be reviewed with prescribers for the teams.
Yep, yeah, no problem. Yeah, it may also, instead of the slide, it might be better to even just open up the form in your EMR with prescribers and get them to click through it. It might sink in a bit better that way if you try that. Okay, no other questions there. I think we can go back. So what's next? And you've already heard me say many times that I think the number one thing we need to do as a broader system is get our quality improvement work embedded as part of our regular work with some protected time. And that's what's going to allow us to continually improve, adapt as new treatment options come available and as new knowledge becomes available. We want to be able to get that reliably into practice to improve care. It's not good enough to just know. We need to reliably do that to improve. And good thing is there are more and more resources for you and your team and your physicians to do this sort of work. Okay, so Andrew is going to talk about some of the health authority specific things. I'll mention more generally, probably most people have heard of this new family practice payment model. So there's now there's time to do quality improvement work, funded time for physicians there. These are just all the things I'm involved with, kind of cues me to mention some of the resources. Hope to Help is the clinic I'm in the downtown east side, and we're lucky to have a lot of funded time to do quality improvement, both with me as the lead in a part-time funded role, but also as the team as a whole. we're closed to patients for the first hour of every day, right? So that's a lot of time for us to work as a team to do things like quality improvement, case management, disengagement rounds. Really allows us to keep updated and keep improving and adapting because we have that protected time. That's a lot, an hour every day. You're probably saying that's impossible, but it's good. QI starts small, right? So you don't have to immediately shift to that. But even getting an hour a week or half an hour a week, start with something and then build from there. So in terms of funding for QI training and projects, if you have physicians interested, there's a PQI training. Interior Health has a PQI program. They can get sessional funding to get training in QI, but also do a project. The opioid use disorder related projects would be great. Shared Care also has funding for quality improvement projects. And I'm on the Shared Care Committee, could tell you more about that. Health Data Coalition. So there's a system for measurement, QI measures, gleaning from electronic medical records. So resources being developed there, similar with MSPQI. That's a measurement system for physician quality improvement. Should really be for physician and their teams, but really the government and Doctors of BC is looking to create a system to make these QI measures more easily available. And then for your family physicians, there's also the practice support program. So anytime they want to do more of an ad hoc QI sort of work, you can get sessional funding and coaching and peer mentoring with that. So keep in mind, tons of available resources. It seems to be growing month to month, year to year. So I'm optimistic with this. The question is just with your team, how do you get started to that journey of getting QI embedded in your workday? So I'll give it over to Andrew.
Thanks,
Thank you.
Cole. All right, so I drew some inspiration from the Vernon team here and their cookie metaphor. Thanks for doing that. And so what I want to talk a little bit about here is just all of you are so involved and so passionate about all the work in your local clinics and all that. And I've had the fortune to have worked with most of you and most of your clinics and most of your coworkers and your leaders and everything like that. And so I'm so happy to see you all here nearing the end of this journey. And so just wanted to talk about what are some of the Interior Health Authority things that are continuing and that we can look forward to in the coming weeks, months, and years. And the first thing I wanted to start off by talking about is the MHSU network. Everyone is familiar with the MHSU network and has probably interacted or intersected with me or my colleagues or much of the great work that our collective teams do. And ultimately, the MHSU network is here to support you and your practice, right? So we support leaders and we work closely with the ministry to do lots of strategic planning around substance use services. We work directly with many people, helping with practice support, so helping to develop guidelines, helping to look at the available evidence, working with various stakeholders to make sure that the products and the practice that we're endorsing, is based on the need, based on the evidence, all that stuff. And then of course the third thing that the network does is help teams and programs and people engage in quality improvements in many different areas. And I think Boost has been such a wonderful example of like a very targeted quality improvement initiative that I'm so grateful we were able to do this in OAT. One of the things that you've heard about in the last year, last spring, there was a BC Coroner's Death Panel review that was released that highlighted a number of findings, characterizations of people who are dying from toxic drug events, as well as a number of recommendations and calls to action. And the outcome of that, if you didn't follow through the news, the provincial government created something called the BC Select Standing Committee on Health. And so this and it was led by our elected representatives, and they met with all of the health authorities, as well as experts and peer groups and nonprofit agencies. Everybody who's doing this work had a chance to be heard by this big provincial committee. And after they consolidated and kind of, went through all the information, came up with a number of recommendations. And one of the things that really stood out from it was the ongoing need to optimize OAT services. Honka did such a great job this morning talking about the evidence behind OAT. All of us do this work. I'm sure we're very well acquainted with the evidence that it prevents deaths and it improves quality of life, and it's like the intervention. But yet we struggle to get people on OAT, and we continue to struggle to retain people on OAT. So through these engagements, including a number of organizations and people with lived experience, they told the province loud and clear that there are ongoing opportunities to improve the OAT system within British Columbia. And so they're kind of looking at they being the province and all of us, we're kind of looking at these three key areas. So the access and reach, how do we, find people with opioid use disorder, and how do we, screen for and initiate treatment for people with opioid use disorders? Thinking about the system capacity, this is, looking at people who are able to prescribe. Some of you are nurse prescribers, and that's such an incredible success story from Interior Health, I think, about being able to, expand that reach to people by having all of you doing this incredible work alongside physicians and nurse practitioners. System capacity also looks to other areas like emergency departments, to primary care, to any place that serves people who use substances, and how do we connect them with OAT. And then of course the third one is retention, and Boost over the years has been such a great example of that of course the government looks to as this great example, and having seen so many people in so many clinics involved with this over the years, and how to continue to do this retention work even after the collaborative ends. Those of you who get the BC-CSU prescriber blast, you probably saw a reference to this new document and some guidelines called the Integrated. Well, IMOTE, I guess, is the acronym for it, another acronym for us to learn. And this looks at changing the pharmacy, changing the pharmacy piece of it, where potentially it allows for a pharmacy or for a clinic to have medications in the clinic to be able to dispense to people. In the documents, it talks about possibly having ward stock of medications in a clinic. So if you needed to do a restart, you're able to have the medication right there. And as we learn more about this model, and as we figure out how to use this model in clinics, there's also going to be an important piece about pharmacy entry. So basically, if the pharmacy is going to be dispensing the medication, the nurse, typically it'll be the nurse, will pick up all those pharmacy pieces. So the counseling, the missed dose monitoring, missed dose notifications, getting the new prescription if it's, if they need to restart or start at a smaller dose. So a lot to learn about this new model. This is going to go hand in hand with an update to the opioid use disorder guidelines that the BC-CSU released back in 2017. There's a whole new version of that coming out sometime this year, and this is one of the things that's going to be referenced in there. And like I said, there's lots of us lots of things to figure out in the health authority, especially when it comes to keeping controlled substances in our various locations and communities. And you can look this up on the BC-CSU website. It gives lots of detailed information about that. Most people here are probably aware of some other initiatives that have been going on or are happening right now. And you know, we've talked about nurse prescribers, and again, I think Interior Health is such a leader in this area across the province, that we're able to offer this service to be able to bridge that gap, especially in so many small communities that where it's been difficult to connect people with OHE. So great work, all of you who are nurse prescribers, and great work to all of the future nurse prescribers that are going to be trained and hired. Many people have probably heard of the ED Suboxone work that was done primarily with the ED Services Network, and now the 29 emergency departments around Interior Health, they've all gone live, and they've all started to do this work, and it's a wonderful service, again, using nurse prescribers to kind of take care of that bridging part. So if somebody is from Lillooet Hospital or whatever, they can be started in the emergency department there, and then have the nurse prescriber kind of follow them until they're able to connect with the local prescriber in Lillooet, and same in any community. And then with the MHSU network, we're part of the extended family with the primary care transformation folks, and so we're looking at ways about how to support people with opioid use disorder who go to primary care for help, and how to connect them to this OAT treatment. I know the use of the EMR comes up quite a bit for everybody, and lots of clinics and lots of prescribers. You know, it's been quite the journey over the past few years as everyone started to using and get used to Profile, and we're always looking for ways to improve the EMR system based on the feedback from everybody who used it. So Cole showed you a picture of the the electronic form. And so pretty soon we're going to have all of the various medication options that prescribers are asking for, including lots of those prescribed safe supply medications, because the fentanyl patch programs, they also use Profile. The injectable OAT clinic, they use Profile. So we're getting all those medications in here, so that you don't have to do some prescriptions in Profile and then some prescriptions handwritten. And then hopefully by adding those additional medications, we're going to be able to improve that dashboard that everyone has looked at and tinkered with and said, oh, it doesn't look quite right. So we're going to be able to improve that dashboard that hopefully gives you a wonderful tool as you carry on looking to improve how your clinic delivers service. A couple of clinics use it right now, but we're going to turn the switch on, so to speak, so that every OAT clinic is going to have the ability to send automated appointment reminders through text for people who have phones and people who have a phone number. Well, it'll send a SMS text reminder to the person the day before their appointment. And then finally, we're going to look at some of those operational reports that exist within Profile. If you've talked to colleagues at other clinics, you may notice that some of the reports look different. The report list looks different between clinics. So we're going to look at trying to get everyone the same type of reports so that you can use them to support the work in your clinic, whether that's basic, which clients live in which city. There's the missed dose report. Based on the missed dose notifications that come in from pharmacy, you can run that report and you can see people how many consecutive doses they missed, which medication they're on, those kinds of things. So we're going to make those hopefully more useful for you, and then eliminate the ones that people typically don't use. We're also looking at yes, Cole, you got a question?
That's awesome with the text reminders, and I just wanted to share that's one thing we really tested at Hope to Help, and so we also tested the difference between morning of and day before, and the morning of seemed to work a lot better. So just information you may want to see if you can test something around that.
Sounds like a PDSA for us, eh? Awesome. The other thing that we're thinking of doing at a regional level is a client survey for people in OAT clinics that will look to measure some other things that that aren't built in profile right now. It may be things that you talk to your clients about, talk to your patients about, but think an earlier version of Boost, they looked at quality of life measures, and people could use that as a measure, based on the responses. We want to see an improvement in the quality of life scores. And then we've also seen some great presentations from they're called Kalala Lalem. They're an indigenous agency in the downtown east side, and they've been doing some interesting research about their work and their retention. And they use measures like how much money a person has spent on drugs in the last week. Have they experienced cravings or withdrawal in the last week? So we're going to do some work to kind of work with the clinics and then of course work with privacy and all those kind of people to come up with a survey that's going to help us understand our clients better and be able to have some additional measures. Kelsey?
Yeah, I just quickly wanted to share, Andrew, and I'm not sure that it we would have had the chance to bring it up yet, but there are 3 teams that will be launching a survey for about a month to get input from the group or from OAT clients around, it's more focused around the barriers to accessing or staying on OAT. So we can certainly, we'll analyze those results and share for other survey development.
Awesome, thanks, Kelsey. I think I've even ordered some iPads to be able to put in waiting rooms at clinics so that when somebody is right there, they can pick up a device and be able to do it right there if that's convenient for them. And then the final structure thing I wanted to talk about is the existence of the Toxic Drug Task Force that, and Debbie's here. She's one of the leaders, the co-chairs of that task force. And this is part of essentially the emergency operations structure for the toxic drug public health emergency in the health authority. So the role of this committee, it monitors the trends. So our medical health officers and epidemiology and surveillance team, they attend regularly to tell us what's happening in the health authority and in our communities. And then through that information, we're able to develop urgent responses. If we see there's a sudden increase in overdose deaths or ambulance calls for overdose or something like that, we can pull together a smaller group to look what's happening in that community and how we can provide some short-term supports or medium-term supports for a particular community that's seeing an increase in overdose activity. This is also a structure that kind of provides the accountability for all of the investments that come from the government. So many of the substance use related services, they're part of targeted funding that comes from the ministry, and the task force is one way to make sure that we're using those funds properly and using all those funds, period. Hey, Debbie? And then it's also a wonderful opportunity for all the various people to highlight great work that's happening around the region and in communities, so that we're able to share your stories and your success stories with the various different tables and various communities and local municipalities and all that kind of stuff. So I'll pause there. Debbie, did I miss anything? Did I capture what the Toxic Drug Task Force does?
I think you did it perfectly, as always, Andrew. I think I would add one of the things that we've all benefited from, and just to expand on that, is the prevalence of our peers at that table, and the lens that they kind of bring to that work, and even in terms of the support sometimes that they give us when we're carrying some of the heavy weight related to this work. So no, as always, you did a fabulous job, Andrew.
Thanks so much. Oh, yeah.
And then just to wrap it up, all of you know how to get in touch with us, whether that's reaching out to us directly or through your, team leaders or managers or whatever. Our job is here to support you.